Welcome to today's meeting of the Health and Wellbeing Committee. My name is Griffiths and I am the chair of this committee. If the alarm sounds, the premises must be evacuated immediately. Do not spend time collecting personal belongings. All emergency escape routes are clearly signposted. Once you've left the building, the assembly point is in the High Street opposite the Guildhall. This is a public meeting and members of the public and press are permitted to report on the proceedings. Reporting includes filming, photographing, making an audio recording and providing commentary on proceedings. Please note this meeting is recorded and streamed live. These recordings are published on the relevant meeting page of the Council's website. By choosing to attend this public meeting, you are deemed to have given your consent to being filmed or recorded and for any footage to be broadcast or published. Members and other speakers are reminded to use their microphone when speaking. Julian, do you have any substitutes this evening?
Yes, Chair, we do have some substitutes this evening. We've got Alan, Bill Amos is here for Steve Mackay, Andy Roberts here for Lucy Hodgson, Marc Bayliss for Stephen Hodgson, Matt Lamb for Robin Norfolk.
Thanks. Do we have any declarations of interest? Councillor Roberts?
It's not a pecuniary interest or anything, but as a member of the Health and Wellbeing Board with overlaps with one of the agenda items today.
Thanks. Councillor Denham?
Yes, I mean, I'm just not a full member of the Health and Wellbeing Board, the County Health and Wellbeing Board, because I am representative from this council, from South Worcestershire Councils on that board.
Thanks. Do we have any public participation? Right. Our first report this evening is on the Worcester City Joint Strategic Needs Update. I believe Matt Fung will be presenting that, the consultant in public health from Worcestershire County Council.
Thank you. I'm just going to wait for this camera to focus on me. I'm assuming that's going to happen. There we go. Wonderful. So I'm here to give a presentation, yes, about health and wellbeing needs in Worcester City, focusing to a degree on COVID, but obviously not entirely focusing solely on COVID. So if I could ask for the slides to be put it, that would be fantastic. Thank you. That's great. Wonderful, thank you. As has been said, I'm Matt Fung, I'm one of the consultants in public health from Worcestershire County Council. I have a lot to do with Worcester City and have done through COVID with the incident management team in Worcester City and obviously deal with the COVID response more generally, but have really a focus in public health on data intelligence and really providing a narrative around health and wellbeing. If you could jump onto the next slide, please. Thank you. I thought, I'm sorry, I thought the screen may be a bit bigger. I will talk through the slide. What I wanted to do is just set a scene around the population structures in Worcestershire compared with Worcester City. The shapes of the two diagrams on the left shows Worcestershire, on the right Worcester City. You can see just from the shape of those population pyramids that actually Worcestershire has an aging population. There's a bulge at the top of that kind of pyramid, as you might expect. And on the right-hand side, actually, Worcester City has more of a bulge at the bottom, which indicates a younger population structure. That's important. So too are the charts at the bottom. These indicate indices of multiple deprivation for Worcestershire on the left and Worcester City on the right. What I wanted to highlight here was that actually in Worcestershire, 12.7% of the population are resident in the most deprived deciles of population. So the most deprived in the country, actually. That equates to 75,000 people. For Worcester City, that figure is 17.5%, which is almost 18,000 people. So proportionally, in Worcester City, there are a lot more deprived people living in the city compared with Worcestershire as a whole. And that is important to recognise as well. So there are many more people and a greater proportion of people who may be struggling the most, actually, because of COVID, even pre-COVID, with various facets of life. And we'll talk about that in a little bit more detail. Next slide, please. I feel like the Prime Minister with the next slide. I haven't done this before because I normally press the button myself. Okay, so this is just a map of Herefordshire, Worcestershire. Again, you won't see the detail on this, but broadly speaking, where you see the purple blobs, those are the wards which are in the most deprived decile. So from the chart that you just saw before, this is the map of it. And if you go on to the next slide, this provides a bit more resolution for Worcester City. So some of you will have seen this type of thing before. This is kind of the central band running through Worcester City, and you can see those Dines Green and that kind of as those other areas, that if you were to focus resource and to focus attention on structural inequalities, on the health and well-being of the people who would most benefit, those are the areas that would most benefit from intervention, pretty much across the board. I could show you any chart about kind of cardiovascular disease or respiratory disease, people who die earliest from cancer, etc., etc. Those are the areas that you're going to find the most kind of disadvantage, the earliest death, the most need, the lowest access to services, the lowest uptake of COVID vaccination. Whichever way you cut it, these are the areas that you would want to focus on if inequalities and improving, frankly, the health and well-being of the population is kind of what we're talking about. If you want to pop onto the next slide, please. And the next one. So just a little bit about COVID. I'm not going to talk to every facet of each slide, but the principal purpose of this slide is to say that actually COVID has multifactorial impacts across delivery of healthcare, on population health status, and on, frankly, socioeconomic status. Okay, so it's to say that you can't just focus on COVID as a single issue. You can't just focus on delivery of healthcare as a single issue. Actually, all of it is intertwined. You have to focus on, improving life chances, the livelihoods of people. You have to think about more broadly, what is the health and well-being status of people, not just have you been impacted by COVID and have you been into hospital because of it. Often, people who are obese or people who smoke or people who have pre-existing long-term conditions are more likely to go into hospital, etc., etc. So all of it is intertwined, and this is just to frame kind of COVID and its effect on population health. And this is the provision of healthcare services, but actually it's the provision of any public service, I would argue. Next slide, please. Again, apologies, you may not be able to see this. Hopefully you will have had the chance to review the slides prior to the meeting. This is just to say that COVID hasn't just had negative effects on our economy, on our population, on our place. There have been positives that have come out of this. For instance, people have really galvanized in large part around providing help and support to people who need that help and support. Through our county Here to Help response, we've had thousands of offers of help from residents and our population to others who may have struggled through the pandemic. People have become more cognizant of health and well-being. There has been, arguably through the Prime Minister's experience with COVID himself, a renewed focus on obesity and physical activity. And that's been true, and we've seen that through much of the kind of response from our population locally. So there have been many effects of COVID, and all of this is presented in a JSNA health impact assessment of COVID that we've published on our website. Next slide, please. And yet, inequalities in COVID have been exacerbated. We know that the effects of COVID haven't been felt equally across the population. We know that those people who had pre-existing disease, who have had a high risk of exposure, notably our more deprived population who perhaps haven't had the ability to isolate at home like other people. Where there's been a stay-at-home order, many people who are more deprived have jobs that require them to be in, perhaps a factory or a packing facility or working on a farm, or particularly in Redditch, huge industrial estates that have been the epicenter of many of our outbreaks. And so risk of exposure is not uniform, and therefore risk of the effects of COVID have not been uniform across the population. Changes in provision of access to health and social care and essential services. Well, I think people have done the best to kind of find their way through kind of COVID, through changes to services. How people access those services is not uniform. So some people just have the digital access to kind of do their online appointments or to jump in the queue the quickest. And that's great, at the expense sometimes of people who don't have the access to those same digital tools or don't have the expertise. And so we have got a bit of a digital divide. We did pre-COVID, and we certainly have now. We assume that everyone has access to the internet. Actually, it's not just our older people. There are younger people and younger cohorts as well who equally have either problems with paying for access, or problems with digital literacy, or problems with the technology, owning a physical device. And so it's fairly structural, even in terms of accessing appointments and that type of thing. Risk of dying is there. I think we're all fairly cited on some of the issues around being older, being male, living in deprived areas, and some of our kind of Black, Asian, or minority ethnic groups who have suffered kind of mortality because of COVID, perhaps to a greater extent than white counterparts. Of course, that is kind of entangled up in this deprivation space as well. Some of that is related to deprivation. The chart on the right isn't, the label fell off that chart, but that is showing death per 10,000 population by deprivation decile. So on the left-hand side of the chart, more deprived; on the right, the least deprived or the most affluent, and the final chart is actually the average. So I haven't put any stats onto that because all you need to do is eyeball it. Basically, the more deprived you are, the higher the chance of death has been because of COVID. And conversely, the more affluent you are, the lower the risk of death has been because of COVID. And whichever way you cut COVID, it always impacts the most deprived in the most profound ways, including death and mortality. Okay, next slide, please. And again, I won't talk through all of this in great detail. As I was saying to Lloyd just before this meeting, any one of these topics I could talk all evening to you about. Not that you want me to do that, but there's so much depth in exploring these issues. We could literally have a workshop on each one of them. We've assessed as much as possible with partners, with the CCG, with the Acute Trust, Community Trust, and DCS, etc., and district partners, of course. What have the impacts of COVID been on services? What have they been on, education, on children's learning, on our more vulnerable cohorts, such as people with learning disabilities and autism, etc. And again, it's been mixed. I think out of all of this, some of the most profound impact has been around education, as we know. Again, pre-COVID, I keep going back to our most deprived cohorts. Children who were eligible for free school meals had the roughest ride in terms of their educational outcomes. All that we know is that because education has been so disrupted over the last 12 months at least, is that that's not going to have improved the educational and life chances and prospects for our most deprived children. That means that the vicious cycles that we've seen in the past are not going to go away without very concerted efforts from Worcester Children's First, from County Council, and arguably from District Council, VCS, kind of NHS, everybody working together. It's a really profound and important issue that we have to get to grips with. Otherwise, in 10, 20, 30 years' time, we'll have even more children who have grown up into adults with fewer prospects, with less skills and employability around their kind of their being within Worcester City and frankly across the country. So it's a really important issue that we need to kind of get to grips with through additional offer, through support, through tailored support across the county. There's lots more there that I won't go into in specific detail, but obviously it's there should you wish to refer to it. Next slide, please, and the next one again. So just moving on to some non-COVID related indicators. I just wanted to bring out some economy and employment type slides because these are some of the drivers of potential health and wellbeing indicators going forward. Top slide there. don't know whether that, again, I think the title has dropped off the bottom because of formatting, but effectively the green line is Worcester City employment rates, proportions of people who are of employable age in employment. The blue line is the mean for Worcester SIP for neighbours to Worcester City. Striking, isn't it? The green line towards the right-hand side of the chart and the drop-off in employment across Worcester City. You may have already been cited on this, so apologies if you have already kind of seen this type of chart before. But that's where we're at currently, running to the end of last year. The chart, the table at the bottom shows the coronavirus job retention scheme, so furlough. Numbers and proportions of people currently on furlough, which expires at the end of September this year. Okay, so that's 5,500 people in Worcester City currently on furlough, 11% of the workforce, approximately, which is slightly higher than SIP for neighbours. My challenge to County Council, as well as to Worcester City, is this. At the end of September, what do we think is going to happen with these 5,500 people currently on furlough and the jobs that they were doing prior to COVID? Some of them will return. Some companies will go back and effectively rehire those staff, and a proportion of them won't. At this point, I have no indication what that proportion will be, and therefore the risk, frankly, to the population in terms of ability to pay for bills, to pay for accommodation, to pay for, frankly, everything that needs to be paid for. And therefore, the quantum of people who will need kind of continued job seekers allowance and other job related benefits there. So again, challenge to county and challenge to district is, how are we going to support those people? In what ways are we going to support a population who, frankly, may not have experienced redundancy before, may be at a loss as to how to support their families financially going forward beyond September? We have 2.5 months effectively to get to grips with this situation, and it's not a long period of time to figure out actually how we're going to pivot things around to help arguably some people who may not currently be vulnerable, but could be vulnerable in the future to everything that we're talking about: depression, anxiety, physical health needs as well. Homelessness, rough sleeping, all of it is interrelated, and this could exacerbate that very kind of theme. Next slide, please. The top chart is just a replica, a duplicate again, and the bottom chart is around those unemployment-related benefits from March last year. So you can see that spike, and that's kind of continued along. So again, there's a proportion of people who kind of had to claim from March last year, continue to claim, and that could jump again come September. So we just need to really be cognizant of these impending problems that could come along, particularly in terms of our economy and our people. Next slide, please. Right, just quickly scooting on to some health indicators that are pertinent and relevant to Worcester City. There's some narrative there that I won't read through because we will cover off that during the next indicators. So if you hop onto the next slide, the way that this works is it's a RAG rating system. So red indicators are those that are significantly worse than England. Orange indicators are those that are similar, round about England average. Green is significantly better. So that's kind of, broadly speaking, what we're looking at. So if we go on to the next slide. Again, I'm sorry that you can't really read these. I'll kind of focus on the red indicators here. So I'm not going to labor this point too much because these are just a selection of indicators that I think are relevant and important. There are many hundreds and thousands more that could completely overwhelm us just thinking about it. So these are just a selection of some of the most important ones. The first red one there is mortality rate from all cardiovascular diseases. So 84.4 deaths per 100,000 population, which is significantly higher than England average. That's why it's red. The thing about these red indicators is that the risk of death from cardiovascular disease is not uniformly distributed across the population. There will be a high risk of death from cardiovascular disease in our more deprived populations, coming back to that original band that you saw on the map that I showed. And so all of these indicators, you have to kind of think, actually, how is that skewing everything that we're talking about? How are people who are more deprived and more vulnerable to cardiovascular disease? And I think that's fairly obvious in terms of diet, physical activity, knowledge, ability to change, money to pay for good and healthy food, ability to access sports facilities, and motivation to get out initially. Have they been brought up? Did the parents actually do any physical activity at all, etc., etc.? And so it goes on. And so that's our first indicator. The next one is estimated dementia diagnosis rate, which isn't so much for this committee. It's just to be kind of cited on the fact that the health service, particularly primary care, are doing a lot more locally now to try and identify people who may have dementia, because we haven't been doing quite so well on identifying people who are probably going to have dementia across the system. So that's the next one. Next slide, please. Percentage of smoking during pregnancy, significantly higher in Worcester City than England. Really an indicator of deprivation, possibly younger women having children, and also an indicator of women potentially taking more risks with their health and well-being than perhaps they did in the past. Then breastfeeding there is significantly lower in Worcester City than, again, England average. So the next slide, please. There's the next red point on here is around statutory homelessness, which is higher than in Worcester City than England. But you might expect that because of the geography, and this is a city, so that's an indicator that you might expect. And then the next slide. I just wanted to put up a quick overview of the red rag Worcester City public health indicators, just to kind of pull those together. So you've got smoking in pregnancy, breastfeeding, school readiness, utilisation of outdoor space for exercise and health reasons, life expectancy for males, I've popped on there as well, inequality in life expectancy for males and females. So that's the most affluent live significantly longer than the least affluent. So in Worcester City, as well as Worcestershire as a whole. You've got noise complaints, homelessness, cancer screening there. Again, it's a health thing, but also I think everybody has a role in promoting kind of screening. It's a service universally accessible to all, theoretically, but clearly not everybody is accessing that. Mortality from cardiovascular disease that we've covered off, hip fractures, and estimated dementia diagnosis rate that we've covered as well. So just onto the next slide. This is my penultimate slide. And this is just to say that COVID has hit and affected everyone. No one is the exception to this in different ways. However, inequality in its own right will surpass the effect of COVID in terms of mortality very quickly in just a few months and years. And if you think about the response that we've had to COVID, the many hundreds of billions of pounds that have been spent on it has kind of achieved what we've achieved. But for inequalities as a big, broad area, actually, that's where we need to be putting our focus next. And as inequalities have kind of been put into the spotlight, they've had a spotlight shone on them really over COVID. The NHS is now more focused on inequalities. Primary care, just last week, have been told that they need to focus on inequalities. Find inequalities in your practice population and deal with them, or try and deal with them. That's what GPs have been told to do. The acute trust, the hospital, they kind of traditionally, hospitals have just treated people who needed to go there through A&E or needed a hospital admission. They need to think about inequalities. How are their services structured that potentially are weighted against as many people as needed to access those services? So really the agenda is rising nationally. Public health obviously has always kind of advocated for deprivation and for the inequality sphere, but now lots more people are being kind of invited to work directly in this space. Just onto the final slide. This is a thank you on this slide, I think, but really what I wanted to kind of draw into a conversation is something about, so what does this all mean? How do we, as a city council, do something about inequalities? I think, you know, that there've been some massive positives through COVID. We've had different ways of working, you know, pulling together different kind of incident management team meetings, including health and the police and, you know, primary care into meetings with the district council and public health and all the rest of it. How do we therefore tackle cardiovascular disease, respiratory disease, air quality, cancer screening, poverty, inequality through the things that are in the control of the city council? How do we change the built environment to promote physical activity, to get people out and about, to move away from kind of you know, vehicles and that type of transport to walking and cycling more? How do we get the right people walking and cycling? Because I guarantee you, if we built some new cycle paths tomorrow across Worcester City, it would be the middle classes that use those. So therefore, how do we make all of the activities and initiatives that we know work for those that may benefit the most from them? And on that, I will leave it. So thanks very much for your attention.
Thank you very much. That was a very informative presentation. Just before we move on to questions, I just wondered if you could possibly tell us where Worcester City or even Worcestershire County ranks nationally when it comes to deprivation.
The affluent kind of setup in Worcestershire. Obviously, you saw that Worcester City is slightly more deprived than Worcestershire. Worcester City equally has quite a lot of affluence compared with nationally. It is one of the problems that we have locally, because what affluence does locally is that it buries problems that are kind of in the almost undercurrent of our more deprived populations. So great, our life expectancy is pretty good compared to nationally, generally speaking, but not for everyone. In Worcester City, we've got 17,000 people who probably will have an early death, frankly. With children with free school meals that I've talked about earlier, actually, most of our children are fine. They grow up in middle-class families and they pay for tuition if their kids are falling behind, but not for those with free school meals. And because that's a relatively small kind of cohort of kids across Worcestershire, somehow they get missed because actually the majority of kids are fine. And so schools kind of go ahead and that's great, but that's where we need to make a really concerted effort to address those structural inequalities that we see across Worcestershire and Worcester City. It's difficult on one level, but arguably because we're not uniformly deprived like somewhere like Sandwell. Sandwell are uniformly deprived, so everyone's deprived, everyone is struggling, and therefore everyone needs some help and support, which arguably can make it easier because you just need to provide a universal offer to get people up to the same level. In Worcestershire, we're a big county, quite dispersed, generally speaking, but we have an opportunity because we have a small cohort of people to deal with. So how do we want to do that? We need to find new ways of doing things. Otherwise, we'll have this conversation in 10 years' time. Otherwise, and we'll just look back and go, the inequalities are still there, and the kids are still not progressing as well as their peers and counterparts. So yeah, generally affluent, which is good. We need to attract investment. I mean, back to the economy, we need to leverage our position as an affluent place, a place that people want to come and live, actually, particularly now. You know, people probably are coming from London to come and live in places like Worcestershire and the counties, frankly. How do we leverage that for our advantage? How do we build our economy back to not just cater for the middle classes, but people who live in Worcestershire that perhaps aren't, you know, execs or something else in a company? How do we kind of pivot stuff around to help everyone, not just the most affluent?
Thanks. Any questions? Mike?
Thank you, Matt. This will sound harsh, I'm sorry, but it was heavy on diagnosis, but very light on treatment in terms of, and we went through this with the young children argument. If you've got a magic wand, what is the one action you think a district authority could take to start trying to equalise some of those issues?
I think you're absolutely right, and this was the start of the conversation, so I'm glad that you've asked the question. I think we should take 1, 2 or 3 areas and just kind of focus on those. Obviously, yes, the diagnosis, it's really broad ranging. One, we need to focus on getting to know our communities. Kind of how have they been impacted by COVID? We have some of that already, and the council are doing some great things around kind of that community engagement. I think we need to leverage our connections and find out kind of what it is that's going to help those people. Maybe people don't know about, I don't know, some of the kind of offers to help reskill people, for instance, in terms of their employability and their kind of their skill set for getting another job. Maybe it's kind of, you know, they've been suffering chronic illness and they don't really know how to get out of that. I think it's about finding out about what would help those communities. Because I could say, wouldn't it be great if we had a load of multi-use games areas smattered around, you know, those purple deprived areas? Are they going to be used without community engagement? Kind of, we could spend a load of money and do some stuff that actually the community don't want. We need to find ways to motivate people to kind of realize that actually, if I carry on down this path, like my life is going to end sooner, and for a greater proportion of it, I'm going to be living in ill health. So it's a bit of a kind of, I don't want to divert the question, but I think it's grassroots community engagement. Let's not do too, because I think as professionals and statutory organisations, we can often do stuff to communities and not engage with them to find out what it is that would help them the most. So it's got to start with the engagement.
Yeah, thank you. It's a very interesting presentation you've given us. And one thing which constantly came to my mind when you were speaking is about the isolation many people now feel as a result of what's happened with COVID. And it's highlighted a problem which existed prior to COVID in so many households, but some more people are now being affected by it. And I'm talking about the people who are stuck at home without any social activities, without any ability to get out of home because they're providing care to children or to parents or to other relatives. But they've got no childcare provision, no access to transport. They feel trapped in their communities, and all they've got is their four walls bearing in on them. And we, as a city council, as a provider of social level activities and as a provider of physical activities, are missing out on trying to reach those people because they are not available. Those services are not really available to them. They are not targeted to them. They're targeted to those middle class people you're referring to, who are happy to go and pay for the gyms, happy to go and pay to join a sports club. We're talking about people here who can't afford to join a club or go to a gym. They can't even afford to get on a bus to go to those facilities. So the fear which I have is, are we in a position to be able to talk about social prescribing, where doctors and GPs can actually prescribe physical activity opportunities to get out of the house? We had a great example in Dines Green of Only Girls Allowed. I don't know if you were aware of it, where we provided, with Worcester Warriors and my divisional fund, provided activities for women on the estate with free childcare. And there's physical activities in the Green Centre. We had sports clubs come in and provide physical activities and training for them. But by the side, free childcare provision was provided. And a number of women who told me this actually saved their lives during that process. But all that's now gone with COVID. So it's the issue of how we actually re-stimulate that kind of activity and how we can try and use the social prescribing methods to actually encourage participation into the services which we provide, but are not getting through to the people who need them most.
And the complex question. There's a lot in there. If I pick up weight management, say to begin with, we've frankly lost track nationally of who is overweight and or obese nationally, because people haven't been weighed and measured. And it's such a concern nationally that GPs last week again had a memo sent through to say thou shalt measure your population and kind of improve our data, because we don't know. Your assumption is probably right that people have become more unfit over COVID. Actually, I think it's polarised. I think there have been the ultra fit people who have used it as an opportunity to get out and about, and arguably the lion's share of people who have found Netflix a real comfort. However, coming back to social prescribing, yes, there has to be the offer in place, coming back to the treatment argument as well, to help people out of that position through exercise and Slimming World and Weight Watchers and all the rest of it, and that is coming online. So that will be a boosted offer going forward, as well as kind of GPs and primary care networks getting involved. The other dimension, I think, around childcare provision and really helping single mums really with childcare responsibilities. That could be something that we could talk about more as this group, from this group. Is that an issue that we want to really push into? Because we know that being a two-parent family is hard enough. Being a single-parent family through COVID must have been horrendous, to be honest. And so there will be a lot of people who have just, frankly, absolutely struggled through COVID, and we haven't necessarily heard their voice. Comes back to the community engagement. What is it that would really help people to not just survive, but I guess to thrive into the future coming out of COVID? But they're great comments, and I think some of those are wicked issues that are really hard to get to grips with, and others do have a practical a solution behind them.
Just following on from what Richard said, I had a lockdown baby, so I've sort of experienced a bit of the lack of services that have been available to parents. I'm quite lucky it wasn't my first, so I was used to a lot of this. But are we at a risk here of having almost a generation of children and families who perhaps have been born during the last sort of 16 to 18 months, where they're almost being set up for failure because those services are not there? There's no health visiting services, or there are, but they're a bit of a postcode lottery. There hasn't been any in Worcester City, as far as I know, but other areas are having them. Are we setting children up for? We've already got massive inequalities and this kind of lost children that we've got in our city who are overlooked because we are, broadly speaking, an affluent area. Are we in a real danger here of having even more? Because children and families are falling through the net. We might be getting women who are going with undiagnosed postnatal depression, children who are going with undiagnosed issues such as tongue ties, tongue tie clinics, so it's having an impact on rates of breastfeeding. Is that something that we really need to be mindful of as a district council?
Again, a complex set of questions. When you come back to childbirth and those early few weeks and months, absolutely critical, and as you say, kind of frenulotomy and tongue tie and all the rest of it, I think could impact, absolutely. There are some children that just need to have those services. We already had a lower rate of breastfeeding, and so lockdown is probably not going to have helped that, because obviously breastfeeding friends type of groups and all the rest of it won't have been running in the same way, and so those support structures won't have been there. So you're right, there will be some issues that start to present that perhaps we're not sighted on just yet, and that isn't that the thing about COVID all over, because I get asked all the time, what's long COVID going to do for our population? What are the impacts? How is that going to affect our primary and secondary care? I have absolutely no idea, to be quite honest. We don't know as a system. The evidence isn't out there. We know some of the broad categories of diseases and issues that could come along. At the moment, we have the things that we've observed. So we've observed, mortality. We've observed furlough in the economy. We've observed things like educational attainment and potential outcomes for those children. Things like longer term outcomes for newborn children during COVID. I don't have all the answers, I'm afraid. That's a research study all in its own right. Some of these things, at the same time, we don't want to over-engineer kind of what the problem could be when it may not have been, because some of it is speculation, and some of it kind of merits further kind of investigation.
So going back to slide 8, you have the mortality rate. Yeah, but do we know how that is additional? Is that all COVID, or is that just the rates at the time, and there would have been a substantial level anyway, or is that?
Those are just
Those deaths?
Yeah, so because it's not titled. Those are the rate of COVID deaths per 10,000 population within 28 days of a COVID test.
Yeah.
So it's in addition to all the other deaths.
Okay, yeah. So it's not they had something wrong with them and they had COVID and that.
The idea is that
would we have seen that level? Would we have seen a chart that was lower than that, but rather than that's all COVID, sort of mean?
That does take into account, that's up to about, I think it's about October 2020. And that represents all of the deaths that have been linked to COVID within 28 days of the COVID test. So these are deaths as a result of COVID, I think you're asking, rather than deaths where people had COVID, but actually they died of something else.
Or they had something else wrong with them and got COVID and it shortened their lives rather than.
That you can't tell from that figure, but yeah. Good question there.
Thanks. Anybody else? Lynn?
Yes, thank you. One of the functions that we have as a district council is our leisure centres, and we commission Freedom Leisure to deliver those services, which is a key part of our sort of health and wellbeing offer, and makes a difference. And kind of picking up on Richard's point is firstly, how can we sort of optimize that contract to reach the hard to reach groups? And then my other question is, if, as you say, health inequalities is absolutely a really important priority, are there funding streams kind of coming along with that in order to do work with communities and to make a difference? And if so, how do we access them, or what do they look like?
Absolutely, and so just to pick up the leisure point to begin with, I think there are opportunities, aren't there, to do things differently. I'm not, I've got to say, I'm not familiar with all of your offer locally, but there are things like so for South Asian communities, for instance, we know that there's a higher predisposition to overweight, obesity, and this diabetes at actually lower levels of obesity and overweight measurements than white counterparts. So therefore, in those communities, there are different thresholds that have to be used. Now, to get women Muslim women, for instance, accessing services, they may need a slightly different offer to the general population. If it is that community and that population that we want to target, then what is it that kind of, in terms of messaging, in terms of the offer within one of the commission services, could that be tweaked? You may already do this to some degree, but you may not, or there might be things that we can do slightly differently. So again, it comes back to the grassroots level, talking to the community. If we put this thing on, would you access it? It's an all women's class, you can go in, it's not swimming, it's some other, could be swimming or some other, group activity. Is that something that would be of interest to you and kind of your peers? And so things can be structurally changed to start to pick that up. On funding streams, there is money that I think has been allocated actually around kind of different priorities, and I'm sure Lloyd can talk about that as well. If not, we can, we've had some kind of money come down through county that's been in part distributed back through district councils, and so there are opportunities, and there are lots of things happening, not least revising some of our offers, kind of bolstering some of our existing services, getting some of the services off the ground, etc. And that would be another conversation, Lynn.
Chair, sorry. Just to pick up on the leisure point and the social prescribers, Matt mentioned earlier the changing landscape really in respect of agencies working together, and it's very much like the sleeping piece that Nina and the team have led on, and how how they're working differently with colleagues. But for the first time in my 20-year local government career, I now have access to a GP to talk to. You know, I now know people in the primary care primary care network on first name terms. We are now having conversations about exercise by subscription, micro local delivery of services, and you know, I hate to say, but this is one of the positives of COVID, if that makes sense. We are now talking, you know, in very granular detail about how we support and you know, help some of these communities. And just to give another example, there is a social prescribing team in place across South Worcestershire, and hopefully in the next couple of months, if not weeks, we will have one of them sitting in the Housing Advice Centre in Trinity Street. So it's just a reassuring piece for me, really, that these conversations are ongoing, and it's very much the focus of our officers' efforts at the moment.
Yeah, thank you, Chair. I think I'm thinking this is very interesting debate and a lot of very useful information, but it's what we do with it as a committee and as a council, and next steps forward. And what I've written down is that we have an opportunity here with this committee, which has been, I think, a great step forward to try and do something really positive. And I would like to see if we can to request a report at our future meeting on access to sport and physical activity in Worcester, and to consider how we can widen the offer to tackle health inequalities within the city. Something which I think can actually have a positive outcome as a result of this committee's creation. And it's something which we can easily do as a provider of some of those services. And we can look at it in more minute detail. But I think what we need first is a report to see what actually is available, how it's accessed, and how we ensure that inequalities are not preventing access to it.
Yeah, I was just going to say, Chair, just need to be conscious that leisure is obviously the remit of Communities Committee. So we just need to be careful on not...
Sorry, Chair, I absolutely agree, but obviously sport and physical activity is an issue of health and well-being. And so there is going to be a clash and turnover, and I can understand that, but I think it's our purpose to look at it from an angle of health inequality and making sure that people have got access to it, where it's another committee's job to actually make that provision. So I think we can have that kind of discussion and debate without standing on toes.
So what I was going to say, Chair, I'm sure a conversation between yourself and the Chair of Communities Committee, you'd be able to find the right way through that conversation.
Make sure that it's done correctly.
Is it within our right and permission now to actually make such a request for such a report, to come to a future committee and allow you to go away and work out the details?
I would say that probably comes under any other business, and I know how much you dislike that.
Sorry?
I said I would say that would come under any other business, but I know how much you dislike any other business.
It's an opportunity here because it's to achieve something as a result of this presentation, which I think could be useful.
I think we'll go away and we can have a discussion with the Chair and the Vice Chair of Communities Committee and see what we're able to do. Yep. Marc?
Thank you very much, Chair. A very interesting presentation. Thanks very much for it. I think I want to come back to the point of where you intervene in the cycle. I mean, I don't think there's anything particularly in this data that has changed much over my 20 years on the council and years before that when I was interested in presenting data like this. And so it's about where do you intervene in that cycle to break the issues, the cycle of deprivation. And I personally, I've always believed that work is the answer. Employment is good for us, and that, not just in a financial sense, but in a spiritual health, mental well-being sense, and that, if we can enable work and people to access work, that will do more good than other interventions. I mean, you spoke about some of the other ways that, through community engagement and other tools. I'd just point out that lots and lots of money has been spent on those over the years, with very mixed results. I mean, there is a drifting average, deprivation is a relative concept. So absolute deprivation, thankfully, is moves away from, but we're still in the just below average, just below the average number. So do you agree that employment is the way to intervene, or do you have? I'm still keen on Mike's question about great analysis, but where do we actually intervene to have the greatest bang for our buck?
Great question, thanks. So on the data, I think some of these issues are fairly entrenched, aren't they? And so that probably is why you haven't seen a lot of change over the years. Where you intervene, I think many arguments could be made for lots of different points. We often talk about the life course approach, where health is over the span of one's life, right from conception, frankly, through to old age. Where on that do you intervene? I think you've got a point around economy and employment. Arguably, financial resources and the cost of funds to kind of live in a healthy way sets the tone for how one may kind of provide for one's family. So the right type of employment is good for health and well-being. That could be kind of one area that you push into. The other couple, I think that there's so much here, as I mentioned before, that it really is about choosing a few, not too many indicators to try and influence, and don't try and do it all, because it just gets lost. We've all been there trying to do too much. You could, I think some have already mentioned employment, sports and leisure, and something about children. Kind of those three things, I think, would start to do something structurally for some of those inequalities and indicators that we've had a look at. What that is, that becomes the detail. So what it is, obviously, that's open to debate, to trying to figure out how best we can spend our money for the result or the outcome. Frankly, how what we do as part of this committee and the city interfaces with primary care networks and the CCG and county, and frankly the districts as well, because it all is interrelated. It's a great question. We could spend a long time debating it.
Yeah, but I'm struggling a little tiny bit. And can I explain? I think as a council, we're really, really brilliant at scrutiny, but not very brilliant at doing things. And I sort of agree with Richard that if all we do is sort of sit around and say something must be done, then nothing gets done. But I'm not so dim to know that you can put a great deal of effort in for no return, and all you do is just wasting time. But I would make the point that there are things that we can do by nature, because it's what we do. You mentioned about leisure. Now, I thought in my ignorance that there was a scheme where there was some discounted. So, I mean, we should be aware that there is a discounted scheme for people who are struggling. There's also a discounted scheme for people who want an allotment who are struggling. So we do some things. We ought to be aware what we do. And then there's those areas which we probably aren't aware enough, where we hold a responsibility. Housing, I know, is brilliant, housing authority, but there are other things like licensing, planning. I won't talk about a specific case, but there's one not too away in the distance where there's an intention to build on green open space, which is accessible to an area where people, frankly, it was on the purple marks. So we're going to build on a green open space, which is a gateway to more open space. And what we're going to do on it, we're going to provide affordable housing. There's something a bit ironic there. So I'm sort of agreeing with Richard. We ought to not just scrutinise, we should look what we can do, but we also need to look what we are doing and seeing, because it's okay to say, with due respect to Marc, it's okay to say that things aren't getting any worse, but as far as I can see, they aren't getting any better either. So I think we shouldn't be complacent.
Apologies for the phone. Is there any discussion going on within public health circles? Having talked to a number of former GPs and some active GPs, do we think there's going to be a diminution of primary care services in the shorter term? I just get a sense of a certain reluctance of GPs actually getting back behind the desk.
That I can't comment on in too much detail. All I will say is that there has been, again, diktat to general practices to offer appointments face-to-face to all patients who wish to have a face-to-face appointment. So there should be ample GP capacity and appointments in theory.
Thank you. Yeah, there's when I've been going around talking to our local residents, one of the things that we've got an older area, and what I am quite concerned about is the time bomb of people who've been left very isolated and alone, and they're dealing and continuing to deal with a situation that's getting slowly worse, and they haven't realised themselves that the situation has got to the state it's in. So I spoke to one poor lady. She'd lost her husband just before the COVID started, so she'd been on her own for 14 months with dealing with her own bereavement away from her friends, and another one who was reeling from the shock of her husband being diagnosed with cancer and didn't know how to deal with it and didn't know how to look after herself. So this we almost need to do a sort of an inventory, but we're going to have to sort of not pry, but we're going to have to coax this information out of people. As you say, we don't know until we've asked these questions. And these people are out there. And another lady who was dealing with dementia and felt very isolated because her husband couldn't understand why they couldn't go out and just kept wanting to go out. And you end up in this vicious circle. And she was lost in the house with dealing with it on her own until I knocked on the door. And sometimes you knock on the door and people don't want to speak, and other times you knock on the door and they'll spend 25 minutes explaining their dire situation, and you wonder what you can do about it. So.
And just to come back on that, you know, there have been some really sad stories over COVID, frankly, and awful stuff that people have had to work through. What I can say is, I guess it's a positive, is data flows coming out of COVID and information about our population has never been richer. Frankly, in my experience of working, you know, in public health and across different systems, we know through shielding data, for instance, which of those people have come through here to help, what types of help they've required, who has been so vulnerable and so unable to kind of even provide basic food provision to their household, that they've required people to literally pick up their shopping and their meds and take it to them. So we have some really kind of granular information about our populations that we should leverage to help people to recover from COVID. So you know, that is there, and we've already used it in various different ways that we can. So it's not as a, you know, a kind of, we're not like a spying authority. It's just to kind of help people through, you know, the circumstances that they've been that they found themselves in.
Yes, Jabba.
Thank you, Madam Chairman. Really useful discussion and thought-provoking input from all the members here today. A number of questions I'd like to pick up on. Councillor Bayliss mentioned something about in the last 20 years, nothing having changed in the city in terms of a lot of areas being remained in those. The question on the back of that to you is that you talk about community engagement, especially amongst minority communities. For so long, nothing has happened, and now all of a sudden you're interested in the AME community, and all the figures are highlighting as such. How are you going to convince them that, and how are you going to earn their trust? How are you going to earn what you say, what you're going to do, and you're actually going to do it? How are you going to change people's perceptions? For so long they've been neglected,
in those communities, whether they be in all across the city, all of a sudden you're interested in them. So that's the number one question. The other question was regarding, obviously, in terms of related to employment. I mean, the key to, I think not so long ago, there was a formula or an algorithm to say the key to a happy life is, £35,000 and 2.1 children, or however many of us. But in order for us to get that, we as a county need to be mindful that our employers look after our employees. I mean, what focus on health and equality and well-being can be given with this in terms of getting employers to pay a living wage, to make sure that the contracts that they give are meaningful and long-term and provides a security and stability that will enable those people in those deprived areas that go for these jobs to make stable life choices and good life choices as a result of them. Thank you.
Great, thanks for those questions. How to gain interest of different ethnic groups. We don't use BAME anymore. It's quite I think that's been kind of eradicated from our kind of abbreviations now. The ethnic groups, I think that we have to start somewhere. So you're saying that kind of BAME groups or different ethnic groups have been neglected or haven't been heard over the last years. And coming back to the last 20 years, actually, what has changed is the ethnic mix of the population has changed. And actually, we're waiting for a year or two before the results of the census are going to be released. That will really help us to understand our populations in ways that we haven't understood for 10 years since the last census. So around those different ethnicities, I think one of the key issues here is that ethnic groups aren't one homogenous group. One of the problems with BAME is that it's like, oh, BAME communities. Well, BAME communities represents tens, hundreds of potentially different communities. And so that has to be recognised. There's a school in Worcester City where children, there were 27 primary languages spoken amongst children. And we found that out because of COVID and because of trying to communicate with parents. So therefore, whatever method we collectively, because it's not just public health, it's district council, trying to engage with our communities, we have to try and tailor and not make assumptions, not be patronising, treat people with respect, and and try and gain that actual insight. And part of the problem is so often surveys and consultations are done for lip service and to tick a box. And we want to get, I mean, I wouldn't be promoting this to this committee if that was the intention. The intention is not for that. It is to gain actual feedback, to do something with that. And I think it's about building trust. You have to start with building trust. There's not an agenda. Well, the agenda is to help the communities out in ways that kind of they need helping. That starts with that relationship. If it's starting from kind of baseline, then so be it. It has to start from baseline. But that voice has to be heard. And it's part of the reason for organisations like patient participation groups within GP practices, or Health Watch, or the VCS. We're going to have to find ways to kind of get voices from those communities that we want to target into our decision making. Employers kind of taking care of their employees. I think it's a really good question as well. The right type of employment leads to better health and well-being. Again, through COVID, I've interacted with countless organisations, many of whom see their workforce as absolutely pivotal to their success, which they are. Employers wanting to spend lots of money on testing, on vaccination if need be, on paying people beyond the statutory minimum wage for sick leave and that type of thing. And so I think we have to work through, again, our business partners with the LEP. It's almost like showcasing what I'd say a significant majority of our employers are trying to do, actually, and just say, this is the way that people in Worcestershire treat their employees. You know, I think there's a bare minimum that people can do. And then there's actually to be compassionate and to actually allow your employees to not feel completely under pressure because of COVID or whatever future health issue there is. You know, these are some things that you might want to think about. Worcestershire works well. Is our county kind of offer approach to helping employers to give the right offer to their employees. Thinking about health and wellbeing holistically, not just for COVID, but you know, mental health and wellbeing. What is the provision and offer in the workplace? Musculoskeletal, it's another issue for Worcestershire as well. MSK problems. How are employers trying to tackle that through HR policies and through types of work that are undertaken? There's a lot, and again, that's a big conversation. But I think it's all about galvanizing support for, you know, the right type of work for our population.
Yeah, one more. It's the last one there.
Yeah. What I thought the question we'd get onto is the, you know, on the business, what can we do? I thought we'd get onto the Towns Fund, which, I mean, just quickly looking at it, you're talking about it's ensuring towns are thriving places for people to work and live, increasing density, strengthening local economy, etc., etc. So it's a better place and tackling areas of deprivation. We don't seem to have got there, which I don't think is very joined up.
Well, this report was it was purely to give us an overview of what's been going on.
It's a bit back to our scrutinising what other people are doing rather than what can we do. And we've got this money that's provided by central government. I mean, putting the politics aside, it is unprecedented for Worcester to be given this level of investment. And we've got to use it properly, you know.
Yeah.
and part of our objectives is to tackle this sort of thing. But that's not a question for you, Matt.
Thank you, everybody, for your comments on that. And thank you, Matt, for coming this evening and spending an hour chatting with us. It was incredibly informative.
It's enjoyable. Thanks very much.
Thank you. I think next we have an update on the integrated care strategy. We've also got another presentation from Sue Harris at Worcestershire County Council. Yeah. Matt, feel free to stay if you want, or if you'd like to.
Anyways, Sue, Sue's there. She's on the health and care trust rather than the county council there.
Oh, okay. Apologies.
Yeah. Good evening, everybody. I've just wanted to check that people can hear me, see me. Is that working? I can't hear you.
We can hear you.
Okay, great. Thank you. And thank you very much for giving me the opportunity to come and do a bit of an update on the integrated care system. So I've worked very closely with Matt, so really useful to be able to dovetail some of what you've just heard with what I'm going to be covering this evening. Yeah, my name's Sue Harris. I do know quite a few of you, actually. I'm Herefordshire and Worcestershire Health and Care Trust, so community mental health, but I've also worked in the county council and the voluntary sector, and I've been around now quite a number of years, very much really around the collaboration and in particular the work we've been doing with sustainability and transformation partnerships some years ago, and more recently obviously around the integrated care system. So also been working, as Lloyd pointed out earlier, much more closely with the districts over the last 12 months. Again, I'd agree that that's been a really positive that has come out of COVID, this really localised collaboration to try and tackle some of what we've just heard around health inequalities, predeterminants of health, and in particular, that's what I wanted to try and get into today is where we are with some of the big structural changes that are sitting in the NHS, but not necessarily to lose sight of why we're doing it and what the benefits are. So I have got a number of slides, not many, because I was hoping we could have more of a time really sort of talking and sharing some of our our thoughts around some of these opportunities. So we could go to the first slide just to set some context. So you will be aware that we're currently out to consultation on government reform of the NHS. So we've got a white paper on the on integrated care systems that's currently coming through in terms of its first and second readings. It sets out a new way of commissioning and delivering NHS services, and in particular, I just wanted to pick up a few headlines here. And most notably, that this isn't a new journey for the NHS around needing to really join up what we do into what other partners are also prioritising. So, we've had this long journey of increasing formalisation, and this paper then moves us into an integrated care system, which will have both the statutory body replacing what you'd now know as clinical commissioning groups, and then having a health and care partnership. The kind of detail of exactly how both of those will work, we're getting guidance out literally by the day. We received some more guidance on some of those changes last Thursday, so happy to talk a little bit more later if that would be useful. But what's really playing through is this permissive legislation, so not a one-size-fits-all, working through how best to wire this with other organisations, and in particular then trying to get different parts of the NHS to work together more formally. So you'll be aware that although we all come under the NHS lodgings, when you get underneath the surface of that, we've often got quite different ways of organising ourselves, whether that is a different organisation that provides acute care like we've got in Worcestershire. My organisation does mental health across 2 counties, but community services in 1, obviously general practice, delivering to NHS contracts, but actually independent providers. We've got local government with that key role in social care, yourselves picking up around things like the leisure and wellbeing agenda. And then we've got the voluntary sector, community groups, and actually all of that needs to come together to try and make sure we maximise where we are placing our priorities, and in particular maximising the Worcestershire pound. So very much for NHS providers, we now will be working to the system, so the kind of the money that we get rather than the organisation specific checks and balances. There is going to be a duty to collaborate. We're still awaiting more detail on exactly how that will look between health and local government, and there's certainly going to be many more opportunities to join up the way in which we make decisions and we allocate resources between local government and health, as well as across the NHS. So if I could go to the next slide then. This is an infographic that tries to capture some of the headlines of the Herefordshire and Worcestershire integrated care system. So just to reiterate, there are 41 integrated care systems across England. We are quite small in comparison to others that might cover, for example, all of the Black Country. You've got some very big ICSs up in South Yorkshire and Manchester. But what we've been trying to do is to just show exactly what sits within our integrated care system and how it works at different levels. So on the right-hand side, you'll see the structures that are coming in now. So we have a new NHS ICS body, very much receiving the money for the NHS, and that will have local government, general practice and broader partners around the table. But actually there'll also be a health and care partnership, and what you'll see beneath that is actually we have got 2 places in Herefordshire and Worcestershire, and clearly they work very differently, and a lot of what we need to do, we will do at place, and a lot of what we need to do will be more localised again, whether that is at the district level or within the primary care networks. And again, you're coterminous in many ways with one Worcester City primary care network, but it's working through which services and priorities you can tackle at those different levels. But that structure just sort of shows you which partners around the table, and as you can see, it then shows yourselves as the districts, and then sort of that broader reach into the community. We've got Health Watch in the VCS, but that's broader. We've got all sorts of other interfaces and structures that we have been really mobilising through COVID, and I think that's possibly one of the big opportunities, is to really shift the dial from the NHS sort of being seen as a national body and it does what it does, to something that actually is more owned and shaped by local people. You'll see there we're a very significant anchor organisation across the health and care sector. So not only do we have a role in the health and well-being of our population through the services we provide, it's also absolutely critical that we continue to keep people in jobs. We've got real recruitment challenges in some areas. So I've been talking to colleagues, when the furlough scheme finishes, is there more opportunities to really employ local, reskill, retrain? Because as we said earlier, and we're all in agreement, work is such a key component of people's health and well-being, and both as an anchor organisation as well as a provider, it's a win-win if we can really think through ways that we can keep people employed into the local health and care system and open up those opportunities for others to potentially enter. A lot of money coming in. So you see the 1.4 billion is the NHS money, and 0.2 billion for adult social care. And what we did over the last year is we moved from what was within the Sustainability and Transformation Partnership, quite an NHS feel and quite NHS driven to the NHS long-term plan, to a reset on something which is much more about the work we all need to do together. So I'm sorry it's a bit small at the bottom, but very much there what you've heard from Matt about this increasing need to identify and think, how can we work together to reduce health inequalities, look at that prevention agenda. We've obviously had significant impacts through COVID in relation to service delivery and backlogs. So making sure that we can drive up that high quality of care and provision. A lot there about, and I've just said about us as an employer, and the physical environment and work we can do there together at scale around digital transformation, building use and working practices, etc. So that's sort of the headline of what the integrated care system is, what our vision is for the next 10 years, the partners that sit within it, and then some of the headline facts and figures. If I could just go on to the next slide though, there are some key aspects that come down through the long-term plan, but actually, again, really do shine a light on where we need to work in partnership. So I wasn't going to go through all of these, but I'd like to just pick up mental health. So there's very much a talk that the mental health pandemic starts now, and we're going to start to see an upsurge in referrals. For example, in my organisation, we've already seen that into our CAMHS crisis services. We're seeing it into our community paediatric services, for example, very much around children and young people with autism, Asperger's, ADHD, etc. We're going to have to think, how do we join all of this together to basically not over-medicalise COVID, but make sure people can get access to early support, and how we can help with resilient communities and not lose some of that support offer that sat within and across communities throughout COVID. So although mental health will have a number of priorities that absolutely will be delivered by the NHS in relation to particular targets, the broader spirit of this is actually, what do we need to be planning for? What does that look like post-furlough? What's the stuff that's stored up for future years, which Matt was talking about? And where are our priorities overlapping? Is there more we could do together? And you could equally say this about all of these components, and just picking up the other one really around the sort of reset and recovery. You know, what have we learned together that we'd want to keep? And some of that has been about really localised delivery, COVID vaccinations approach being one of those, really successful across the county. We built up new relationships, new conversations. You know, how do we retain and maximise some of that? So my final slide is really, and again, you know, Lloyd's been very involved in these discussions, and I know there was another discussion last week with the primary care networks across the south about how do we build up these district relationships. So there are some things that we're all doing, we're all promoting, that are absolutely about prevention, physical, social, mental well-being. We're doing a lot around that proactive and preventative care, and we've been talking a lot about that this evening. There are some services that we could join up more formally together. So, you know, have more of a multidisciplinary approach. When you get to the sort of service line 4, however, some things that we do, we struggle to do at a more localised level, and some of that might be things like, you know, your urgent care, so your A&E, for example. Some of our elective services, so by that I mean cancer services, in fact, some of our mental health services, also we're doing across 2 counties, and there'll be some services, and that might be something like offender management services for mental health. We are too small as an NHS for our population size to do that in our 2 counties. So some of that we do on a broader footprint again, whether that be the West Midlands. So the real trick is connecting it all in at the right place at the right time. But the health inequalities agenda, I've been in the NHS for sort of health and care for sort of 25 years. I've never seen such a real commitment, passion and desire to try and really do this differently. And we need to learn from yourselves, your community connections, and how best to sort of enable that to come to the party, because we really do need to be able to lock in what the NHS is doing rather than seek to reinvent the wheel. So that's one area of significant focus, certainly at the district level. And as I say, really that maximising earlier access, timely access to services, more money potentially that would have gone into the NHS going into voluntary sector, community resources to try and turn the dial. Often at the moment, I think there's a frustration, certainly I hear it in mental health, that you have to wait to be ill to access a service. Clearly that's what we want to be moving away from. We've always talked about prevention, and I do believe that if COVID hasn't given us the impetus for change and given us a way through to actually working differently, I'm not actually sure what will. So it could be seen as a bit of a rearranging of the NHS deck chairs if you sort of just read quite a lot of the formal documentation. But for us locally, we really got some clear commitments to doing things differently, trying to lock in new ways of working, have different conversations. There will be a formal timeline in theory. The new ICS comes into being in April 2022. I think there's a lot of talk now that that might be more of a shadow year, because we've got a lot to do to get the structures in place to make sure that that movement between NHS England, the clinical commissioning groups into the local ICS is safely managed. Clearly there's employees associated with that as well, so there's like a national change management process anticipated. But this just gives you a kind of a run through of sort of what our system's looking like, what our priorities are, and in particular, how do we maximise the interface with yourselves. So I welcome the opportunity for yourselves to give me any feedback, and thanks ever so much for inviting me, because it is a really, really timely opportunity. It's early days, and so it's very much ours still to shape and influence. Thank you.
Thank you very much. Does anybody have any questions? Andy?
Sue can hear me. Good evening, Sue. We've just been having a session with Matt Fung from the Public Health Department and talking about inequalities and something, things like that, which is very much tied in what you're talking about. You didn't use the words commissioning for outcomes, but I think that relates. But can you just, I don't know what it means. Can you just tell me what that means?
Yes, because we do like our jargon in the NHS, and Councillor Robert, you more than most know that. So this is trying to move us to an outcome framework. So much more about saying this is the outcomes we expect, and that might be in relation to longer term goals around, for example, work or particular decreases in things like childhood obesity, you know, but at the moment we're quite targets driven. So there's a move towards something that's more longitudinal, that is more about outcomes in terms of things that really matter to people. You set the budget and the outcomes, then how you do it is left to the discretion of the providers in the main that come together to consider how best to deliver that. So I'm very conscious that Worcester City may well want to do things quite differently to achieve the outcomes that you want for your community, and that might be quite different to, for example, you know, over in Bromsgrove, where I am now. So for me, I think the real trick is making sure that those outcomes we've all got some skin in the game. They're things that we've all collectively brought into, because that's how we'll genuinely move things forward, rather than it just sort of being seen as one partner's agenda. So we've got an outcomes framework. It sets across those sort of 4 areas I showed you on the slide deck. So some of this is about things like the workplace and employment and employing more people, very much about some of the ways in which we want to transform people's choices in their care, get people more involved and taking potentially more responsibility for some of their health and care choices. So we've got a suite of outcomes, you've got the money associated with that, and then it's actually about how do we enable those more localised responses to think about how they're going to tackle it, rather than saying it's a one-size-fits-all, which is traditionally what's happened in the NHS with the targets and the monitoring of those.
Thank you, Chair. I think that feeds in well to our last discussion.
Anybody else? Then?
Thank you. Thanks, Sue, for coming virtually. I didn't know we could have real meetings with virtual people. Thank you. Yes, I mean, I'll take your point about reorganising the deck chairs as, depending on definition, you know, the last major NHS reorganisation, the Health and Social Care Act, I was either a victim or a beneficiary of it. So I've happily claimed an NHS pension now for 10 years and enabled me to do this. And this is different. I mean, thank you for coming here, because I think this is the first time actually that Worcester City councillors have had a presentation about this and some understanding about it. And I think, from my understanding, you know, this reorganisation is going to impact on this bit of the world in a way that the previous one didn't. I mean, a couple of questions with regard to the sort of wider strategy. So we now have a Herefordshire and Worcestershire CCG, and a decision was made to pursue the sort of the ICS format to go down that road. We don't yet have the white paper. So how was that decision made, and how does the governance work when we're still awaiting the legislation? I'm kind of struggling to get my head around that. And, you know, your infographic, there's an enormous amount on that one piece of paper, which is a significant achievement, and actually, no, and it contains a huge amount. So, you know, as a district council, we know our patch, you know, and our world is really important to us, but we're a little white blob down the bottom. How can we influence the agenda, or what voice do we have for our community? You know, there's 4 objectives there, which are really profound objectives, some of which we probably think as a district council we're doing, but we didn't set them. If you're able to kind of help us with some of that.
I'll try, Councillor Denham. And can I also say, I should have said at the beginning, thank you for letting me come virtually. I was actually on annual leave today, but I didn't really want to miss it, but I couldn't get over in time. So I've been able to come in, and so far the technology is holding up. So that's great. Your point about the legislation and the kind of working through the transition. At the moment, the Herefordshire and Worcestershire CCG remains. It would remain a statutory body until the 1st of April next year. So everything we're doing at the moment is receiving guidance and then looking for how that would effectively translate locally. I did flag earlier the timing starting to look a little tight to get this through. I think that there may well be maybe that shadow year to enable then that the CCG is a formal body holding the sum of money that you mentioned on the infographic, to enable that safe transition. Obviously that's way above my pay grade insofar as decisions, but certainly they're working through how to manage the transition. When you get the guidance through, you do look and think, actually, most of this is broadly in line with what we've been trying to shape and design. So the principle of subsidiarity is possibly the most important that I need to draw out here, that actually you do as much as you can at the level where it has the most impact, and actually it's certainly in the ICS context, the majority of that is certainly at place. And for a lot of what I've been talking to Lloyd and his counterparts about, we know there's a significant amount that can be done at district, and especially now because we've got primary care networks. So I think that's possibly the game changer that I think we've seen over the last 2 years. Before we had sort of, circa 60 GP practices, as you know, very hard to be consistent, have engaged conversations, sort of sign up at scale to transformation. And obviously that's completely different now. We've got 10 primary care networks. There is a bunch of national contractual expectation around things like health inequalities and working through the prioritisation of those in partnership. And that would be absolutely key for the districts. So very much at place, we've been talking about how are we going to enable the districts? How are we going to enable as much local focus, certainly around prevention, wellbeing, community, VCS, and the objectives were trying to pull through a different way of working. So then certainly there was some local government involvement. It was turned around quickly in some ways. I say apologies that they haven't been socialised as much as we would like, but to recognise that prior to this, they were feeling very NHS long-term plan. And this is actually about a collective effort. I've done quite a few health restructures too, and this is the one where I really feel that we've got localised leadership coming together, having conversations with a real will within the system to enable that to effectively happen. So we've been talking at place about the districts effectively providing the updates in relation to a whole swathe of things that we're needing to focus on. We won't get this right, but I do feel that it's not helped on the infographic, as you say. It looks sort of fairly top heavy, depending on whether you see it as a hierarchy. I think for me, it's all about prioritisation, and prioritisation being made at a local level, and then it effectively draws the governance in then to support that. And that's very much an operating principle. I didn't know if it was appropriate to ask whether Lloyd wants to comment, been much more engaged, I think, as he said earlier, possibly with the NHS over the last 12 months. And whether some of this is starting to feel different in terms of it not looking like a kind of big bureaucratic machine.
Thanks, Sue. Yeah, I'd probably make 2 points there. I want to sort of reiterate the point again around the sort of the types of conversation we're having now with colleagues, particularly in the primary care trust. But when you look at the priorities of those colleagues, GPs and nurses, they're multifaceted. So take diabetes, for instance, that's a multifaceted issue. And there are lots of things that we naturally do as district councils that we are playing a part. Councillor Roberts mentioned allotments earlier. We have 800 allotment holders they're all doing a level of exercise and activity every week. But we don't quantify that. We can't turn that into health speak. And for me, one of the things that we need to get better at is trying to do that, qualifying and quantifying the role we are playing and championing our own cause, really. So that's the first thing. And then the second thing for me is I think, one of the things that we are, getting more and more acknowledgement around is how, it goes without saying, how well placed we are locally. I think just take Warwick's team and the work they've done over the last 12 months. Health colleagues are just amazed by the level of knowledge that they have, and we know we need to gain more. So I'm not saying we're there yet, but that's a ready-made source of information being able to tap into. So it feels we've got a real springboard to move forward here. Moving forward.
Thanks very much. I just wanted to ask a question about the slide on the health and care workforce. Being a bit of a sad egg, I didn't recognise this figure of about 17,000. I think the health and social care workforce in Worcestershire and Herefordshire will be significantly bigger than that. I mean, maybe it's a small element of it. I mean, we would have a workforce of about 400,000 people. And the health and care workforce would typically be about 10%, so more like 40 or more, 40 or 50,000 people. So I just wondered where this had come from, and how, if you could just, is there something we're missing here? Is the main NHS workforce not included, or?
It depends where you draw the line, as you say. You're quite right. That if we were moving into wellbeing, it would be bigger again. So my understanding is that includes local authority, so county council provided services. I don't think it necessarily reaches out to the full care home market, or does it pick it up? But because it's at the edges of some of that, you start to get into much larger figures. So it's undoubtedly, I think it was those ones where we as partners are directly employing. I will take that point back about the districts and ask that we also come back out and think about whether we can reflect some of the work and the contribution of yourselves into that pie chart. So yes, it very picks up some of that directly commissioned NHS and healthcare workforce.
I think it's important just because it gives people it would give people a different view about how important the workforce is in this sector in terms of employment, the opportunities it provides. I think if you take that wider definition of health and social care, it's probably at least 1 in 10 people work in the sector generally.
Yeah, I'll take that back. Thank you very much.
Yeah. So I do really appreciate the fact that you've joined us while you were on annual leave. So it's very lovely to have had you here with us this evening. And thank you so much for a very informative report.
Thank you. And I say, just to sort of leave you with this is almost like the start of the journey. So I thank you very much again for being able to come in at this important juncture, because we are still waiting legislation. There will be some things that are mandated, some things which we will be able to shape. So I would welcome the opportunity to come to any future meeting and update you accordingly. So thanks again.
Thanks. We'll probably end up taking you up on that offer as well.
Okay, thank you.
And then finally this evening, we've got the Healthy Worcester Plan, the 2019 to 2021 update report, which I think Nina's going to lead on.
Right, I hope that you've all been able to read the report, because it was circulated with your papers. There were 3 sections within the report that I'm not going to go through in detail on the basis that it has been read. There was an update to the committee on the renewal of the Worcestershire Joint Health and Wellbeing Strategy, which is at section 3 of the report. There is the progress made against the Healthy Worcester Plan 2019 to 21, which is at section 4 of the report. And there is the proposed next steps for progressing this area of work at section 5 of the report. The City Council is very much a community leader and has a duty to cooperate with the health and wellbeing agenda. And that's obviously been expressed a number of times from both Fung's presentation, but also Sue's presentation just now. We are a provider of key services which have a direct impact on the social determinants of health, such as employment, the economy, housing, planning, transport, leisure, communities and community engagement, recreation, and environmental health. And all of those things directly impact on the health of the population. It's also been recognised over the pandemic, the crucial role that local government does play in meeting the community health and wellbeing needs. The current Worcestershire Health and Wellbeing Strategy 2016 to 21 had 3 key aims of increasing physical activity, improving mental wellbeing, and reducing the use of alcohol. A new strategy is currently being developed for 21 onwards to meet the needs identified in the evolving JSNA. And obviously Matt's described some of those areas to you. Work is ongoing to update this strategy and it is imminently due to go out for public consultation for a 12-week period. The existing Healthy Worcester Plan 19 to 21 was established to support delivery of those 3 priorities, along with another 5 priorities that we'd identified. And many of those you'll recognise from Matt's presentation earlier this evening. So we've got statutory homelessness was a priority, poor air quality, outcomes to access services for the ethnic minority groups within the population, loneliness and isolation for all ages, and to improve how we can work with our partners to make the best use of our community assets. I won't go through those in detail, but the highlights of the progress are in the table at section 4.3, but I'm happy to ask any questions from that. The action plan will need to be renewed based on the new priorities within the Worcestershire Health and Wellbeing strategy that's just in process of being delivered. And obviously this committee will be essential in terms of supporting delivery of what goes on in terms of that new Healthy Worcester action plan. There are a number of agendas across health and wellbeing that this committee will be able to support delivery, including the integrated care strategy and how we join up what we are doing and work better together. The City Council is also responsible for many services that affect the environment in which residents live, which in turn play some part in the quality of people's lives. The pandemic has reinforced the fact that wellbeing and community is central to local government activity, as Lloyd has already described. And obviously what this means, it's an opportune time for this committee and the City Council to recognise the role we play and how well placed we are to work with health and the county, along with other partners, to address these issues. This will be vital to addressing the health inequalities resulting from the pandemic and support delivery of the Worcester Community Recovery Strategy. So any questions? Thank you.
Thanks, Nina. Any questions or comments on the report? No? Yes. Oh, Lynn. It's a very good report, yeah. We're heavily involved in helping it come together.
Yes, I mean, I realise it's late and perhaps people's enthusiasm for discussing health and wellbeing is somewhat diminished with a cold draft down your neck as time goes on. I'm going to thank you, Nina, for the report and for all the work that you and your teams have done with it, and actually officers across the council. I think what it absolutely illustrates is what, you know, as a district council, the difference that we can make with our services, and, you know, what has been achieved and can be achieved. that with regard, and our sort of future plan will need to take account of the presentations that we've had. And I think we know that the new county strategy, there is a sort of first draft being discussed in private session tomorrow, with a view to it going out to public consultation. The Health and Wellbeing Board sort of form next public meeting is next month, I think. So there will then be a public consultation process that we can contribute to, and that will inform what we as a district council want to get involved with, and what our action plans should be.
I think really to just echo what Lynn said as well, Andy, you pointed out before that we are very good at scrutinising and talking about things, and perhaps not quite so good at getting things done. I became a councillor in 2018, and I sat on the communities committee that approved this strategy, and I think it's fabulous because I can actually see all these things that have been achieved in it, and that's wonderful, and particularly with regards to things like Housing First and the RIP sleepers. That is something that is a real passion of mine, and I think it's wonderful that we've been able to see those projects through. The tennis in the parks as well. I know Richard has been quite keen on those, haven't you, over at Cripplegate Park, and getting the courts up and running. So it's great to actually see all these things coming to fruition. And being able to work with you on this report and the strategy going forward. Anybody else? Richard? Because about tennis I've already mentioned.
Not about tennis in the park, but that highlights an issue which I'm going to raise. One of the achievements which we've celebrating here and in progress is the dementia meeting centres which have been created, and there's one starting this Thursday in Downs Green. I hate to say it, I'm very nervous and worried about its potential for success, because they're charging £25 per day for people to attend. And that's ridiculously unaffordable for the vast majority of people who are suffering with dementia issues, especially in communities such as Downs Green. I'm very concerned that we're celebrating good progress, and it's good that this has been established. But is it actually affordable? Can people actually participate in it? Can people actually work with it? And it's a similar issue with the tennis in the park. Great ideas, lovely opportunities, but it's unaffordable for the larger number of people who live in St. John's. They simply will not use it because they can't afford it. And I'm just worried that we're setting ourselves up to fail if we're not careful.
Do you have any information about this? Because I know when we had the Healthy Worcester meeting last week, we did talk about these dementia centres, and there was no mention then about charge. I don't know whether Lloyd or Lynn, you know anything about these?
Yeah, I mean, I know something about it as chair of Worcester Dementia Action Alliance. So there's also one starting at Age UK offices in the city centre. So there's been some priming money from the county council, which I think has absolutely made it possible to get started. And obviously COVID has delayed it. The difficulty is that the model that is recommended by Worcester University requires employment of staff, and how do you get a financially viable meeting centre? That is absolutely the problem. So there's been one operating, I think, in Ledbury for some time, which has aggressive fundraising, is that the right word? Have worked really hard to get the money. Have got a lottery bid. One in Droitwich has was sort of struggling on the verges of sustainability. So how do we make the financial model work to deliver the need and the services that people need? It's really difficult.
From a city council perspective, is there anything that we can assist with on that, Lloyd?
Chair, I think Councillor Denham's got far more information, is closer to it than me, but all I was going to suggest, Chair, that we take that away and discuss that with WCT and with Age UK to see if there's anything we can support with or link them up with. So we'll commit to doing that.
Thanks. Karen?
One of the dementia sufferers, or the care of a dementia sufferer, said she's been quoted £35 an hour to get a break from her husband, for someone to come and sit with him, £35. So obviously it's unaffordable for her. She's retired, he's retired. So I actually thought £25 remarkably good value for her. But obviously we'd look to, you know, if there's a possibility of improvement on that. And then there's the you know, she wants that. I mean, how precious that time could be, but an hour is very limited, you know.
It's an expensive service. I have a grandmother that's just gone into a dementia care home, and I have a grandfather who's at home with living carers. It is a very, very expensive service. Yeah, I think if we can go away and look into that and maybe have a chat with WCT and Age UK, that would be fabulous. Yeah. Anything else? No? In that case, thank you very much, Nina. And thank you, everybody.
Thank you. Well done for a first meeting.
Thank you, Lynn. I feel a bit rubbish this evening. I've had my second COVID jab and I feel grim. So yeah, I've struggled through it.